What is the blood group? Most common blood group? RH positive. Blood group B positive. Yena. Ayo, this is the most frequently asked question. Well, if you take, I think volume కొంచెం ఎక్కువ ఉన్నట్లుంది. Yeah, fine. So you never did your blood groups in the first year physiology lab. Which college? Huh? Which college? Chain వాళ్ళంతా OMC na? So never had your blood group done. So what was your blood group? So most common blood group is positive or negative? How many of you had negative groups here? Anyone had negative group? All positives, no negatives? So coming to RH negative pregnancy. So first, what do you understand by this RH negative pregnancy? So most of the blood groups, most common is O and RH is positive. It indicates that D antigen is present. So if D antigen is there, we call it as RH positive. If there is no D antigen, we call it as RH negative. So why we are discussing about RH negative pregnancy is, when compared with other than pregnancy in a normal people, we are nowhere bothered, either positive or negative. But in pregnancy, it causes lot of disasters. So the blood group of the mother should be done. So coming to RH negative pregnancy, first of all, why we are most commonly worried is whatever the antibodies which are there in the mother, so they are going to kill the baby. If the mother is RH negative and if the baby is something like O positive, mother is O negative, it is going to, whatever the antibodies are produced, they are going to kill the baby. So that is why we need to do the blood group of the mother. Then how to avoid this and what is the management? So regarding RH negative pregnancy, what are all the bits asked for you? So first of all, incidence. Incidence is 7%. So out of 100 women, if we take 7 people, there will be RH positive. So incidence was asked for you once. The incidence of RH negative pregnancy is 7%. Coming to what are all the various other antigens you know other than RH? Other than D antigen, what are all there? E, C, D, C, E. Okay. And other groups, what other than blood group? Anti-D, anti-Kel and anti-Lewis. Why you need to know all these groups is, they have asked even these groups regarding, one question was asked. And anti-Lewis antibodies. So whenever anti-D antibodies are there, they are going to kill the baby. But remember, but anti-Lewis antibodies, Lewis lives, L-I-V-E-S, means it is not going to kill the baby. So remember code like that, Lewis lives. So it is not going to, even the anti-Lewis antibodies are there, but they are not going to cause any harm to the baby. So this is the one antibody which is not going to cause any harm. Previously it was asked for you. So we have discussed RH positive means D antigen is there. RH negative means D antigen is absent. Yeah. Whatever the Kel or Duffy, both are going to kill the baby. If Kel is there, antibodies positive, even anti-Kel antibodies are going to kill. Whereas Lewis, it is the only one antibody, even though it is present, it is not going to kill the baby. So, suppose mother is RH negative, father is RH negative, is there any effect on the baby? Yes or no? So you want to give anti-Ds and you want to manage, you want to investigate same as like RH negative mother. Suppose mother is RH negative, father. Is father blood group important or not in RH negative pregnancy? Why? Baby's blood group can be either positive or negative. It depends even on the father. Suppose the father's blood group is negative, mother's blood group is negative, nothing, no need to worry. Definitely the baby's blood group will be negative. So the father's blood group is also very important in a RH negative pregnancy. And if the mother, that's what I told you. So if the mother is negative and the father is positive, there may be a chance that the baby is RH positive. So definitely you need to investigate this case. If both are negative, nothing to worry. If the mother is negative and the fetus is positive, then only we need to. So we will see what are all the consequences of this RH negative. So first tell me, Rh negative, which is the most common incompatibility in the fetus? Baby present with hemolytic disease of the newborn. So which group incompatibility we will see in the newborns? Most common. It is ABO incompatibility. So it is not the Rh incompatibility which is most common. Always remember, the bit was asked for you. So the most common incompatibility is the ABO. So whenever you see jaundice in the newborn, if there is incompatibility, it is not because of Rh negative. Most of the times it is Rh, it is ABO other than the Rh. So how? Suppose the mother is O positive and the baby is having either A positive or B positive blood group. So the incompatibility can occur. Finally landing in jaundice. From where this jaundice is occurring? Either hemolysis, there can be hemolysis, destruction or increased absorption. Okay, from the liver, enterohepatic circulation. I think you remember it. I don't have time to explain entire physiology. You know the bilirubin metabolism. Does it undergo enterohepatic circulation or not? So once again it gets absorbed. So these are all the causes why there is jaundice in the newborn. So the most common incompatibility in newborn is ABO, not RH. Okay. So what this RH is going to do? Mother is RH negative. Father is RH negative. Now I am nothing to be worried because even the baby will be negative. Mother is RH negative. Father is RH positive. Mother is something, you can think O negative, father is O positive, B positive, something. So what it is going to happen? So the baby can be either negative or positive. If the baby is negative, nothing to be worried because no antibodies. Whereas if the baby is positive. So now what we are going to do with this? So she is the first pregnancy. She never underwent her blood group until now. So she came to me. She is the first visit. I have done her blood group. Her blood group is negative and the baby blood group is positive. So what I am going to do? So mother's first pregnancy. I am speaking about first. It is her first gestation. And baby, mother is female is negative. The baby is positive. So what are all the consequences? So once this positive, what it is going to do? These fetal RBCs are going to enter into the maternal circulation. So whatever this antigen carrying fetal RBCs. So what they'll do? They'll enter into the maternal circulation. Once they enter into the maternal circulation, always it is something strange to the mother because mother has been negative until now. But something strange has entered into her body, that is positive antigens. So now what the mother will do? It will secrete antibodies to kill the fetal RBC. Okay, whatever the fetal RBCs are there, the mother will produce antibodies. So that these antibodies, whatever are there, they are going to kill this fetal RBC. So they are going to get transmitted and they are going to kill the fetus. This is how it will happen. But the important, what is acute antibody? Acute antigen or antibody. How many are there? Immunoglobulins. How many are there? So what are the acutes? Game. So M is acute. This is chronic. So what they, so once this fetal RBCs first time they enter the mother, they are going to secrete IgM. But very important thing is this IgM is not, it is not going to cross placenta. Yes or no? Which is going to cross out of IgG and IgM? So IgM will not cross placenta. So even though the first pregnancy, the antibodies are there, but the mother will produce IgM because it is an acute. So this will not go to the fetus. So the first time, even though the mother is negative, the baby is positive. You will be coming from the rural areas, I will be seeing. The first time Rh negative pregnancy, she will not be taking any anti-D, but still baby is fine, mother is fine. Why? Because this is the process. It is an acute. IgM, these immunoglobulins are not going to enter the fetus. So they will not cause any damage to the fetus. So the first pregnancy, the baby is lucky. But what is going to happen in the second pregnancy? The second pregnancy is already a chronic process. Now it is not going to secrete IgM, it is going to secrete IgG. So these are going to get transmitted to the fetus and these are going to kill the baby. So now tell me, in Rh negative pregnancy, which pregnancy is affected? Multiple pregnancy or first pregnancy? Why multiple pregnancy? Huh? Why multiple last? IgG? IR produced. So IgG is going to cross the placenta. Fetal RBCs. Is it clear why the second pregnancy is affected in Rh negative? Why the first baby is protected? Whereas in ABO incompatibility, remember, it is quite opposite. I mean, in ABO incompatibility, even the first pregnancy is also, first pregnancy is affected. Okay, that's how we differentiate. In ABO, the first, whereas in Rh, it is the second. That mechanism and all is totally different. Okay, but remember this, ABO, the first pregnancy. Okay, can first pregnancy be affected in Rh negative? Then why we should be worried in the first pregnancy? Are we worried or not? Can there be something damage to the fetus? But how? Exactly. Suppose the mother is having any prior previous transfusions of any positive blood. So already the antibodies might have produced in the mother. So now the fetus, it is going to create a secondary reaction. So now which antibodies are produced? IgG. So even the first fetus is going to get affected. So this was asked for you. So even the first baby of the Rh negative pregnancy can be affected because of prior or previous transfusion, blood transfusion. Okay? Is the mechanism clear? Yeah. So the antibodies cross the placenta and attack fetal RBC, finally causing the hemolysis. That is what it is going to happen. So we call it as hemolytic disease of the newborn, HDN. This is seen in Rh negative pregnancy. What it is going to do? It is going to lyse the fetal cells, entire fetal RBC. So increased erythropoiesis will be there. When we see in the Rh negative pregnancy, how will be the important, what is the important finding of the fetus? Still, final stage, hydrops fetalis. So the baby, what is the feature of the hydrops fetalis? Entire baby is swollen. So if the same symptoms are seen in mother, what do we call it as? Mirror syndrome. So why there is swollen? Why the baby entire something like anasarca? Why the baby develops anasarca? Because whatever the damage is there, the fetal RBCs, they are damaged. So now what the body will do? It will cause increased erythropoiesis. So the hepatomegaly will be there, splenomegaly will be there. Because of this, there will be cardiac failure. Finally, entire body will be landing in edema, hydrops fetalis. If the same anasarca is seen in mother, we call it as mirror syndrome. Okay? So that is hemolytic disease of the newborn. First baby is not usually affected. So previous sensitization can occur due to previous blood transfusions. So that's why the subsequent pregnancies are very dangerous. The first pregnancy may or may not be harmful. But ABO incompatibility is more common in the first pregnancy. Remember this difference. But when compared to Rh incompatibility, ABO incompatibility is not very dangerous. It may cause jaundice, okay? But when compared with Rh negative, it is very dangerous once it occurs. So these are all the differentiating points. So ABO incompatibility, what are all the differentiating points? Differentiating points between ABO and Rh. Yeah, first pregnancy is affected in ABO. Next. Any other differentiating point is there? Which one is more severe, Rh or ABO? So Rh is more severe. Okay. So one more important thing is in a Rh negative pregnancy, we can't do the same things in a normal pregnancy. So whenever you want to do any procedure in a Rh negative pregnancy, you should be very careful. So this was asked for you. Which were all the various conditions which can cause increased sensitization. So normally how much amount of fetal RBCs is required to cause this sensitization? Can anyone answer? Previous bit. How much amount? I told you the fetal RBC is going to cause. So how much amount of fetal RBC can cause sensitization in the mother? 0.1 ml. So even the minimum 0.1 ml is sufficient to cause a sensitization in the mother and is going to kill the baby. So that was asked. How much ml? Minimum is 0.1 ml. Bookul is chepnara. Okay, so what are all the things which are going to cause? So whenever in Rh negative pregnancy, any procedure you do, we should be very careful. So what are all the procedures? Any procedure which is going to cause bleeding. Why? Because maternofetal transfusion can occur in these procedures. So during pregnancy and during puerperium, during labor, during all these phases, which phase you think the baby has got more chance of sensitization? Suppose during pregnancy the baby is more affected, or during labor, or which phase? During first trimester, second, third, or labor? Why? Because the maternal-fetal transfusion can occur during labor. So that's why the amount of fetal RBCs entering the mother is very high. So during labor, any procedure, including all procedures, during labor is the highest risk. That's why most of the times, even though it is protected in the pregnancy, the next pregnancy is affected. Can this fetal RBCs transmit in the pregnancy period? So you told that there can be feto-maternal transfusion during labor. Definitely, because the placenta, everything is out, the vessels are open, so there can occur fetal and maternal transfusion. Suppose she is not yet delivered. During labor, can she undergo any sensitization during pregnancy? You said labor is the most common period. During pregnancy, there can be any sensitization. We did not do any procedure. We did not do any procedure, no complications. She is fine, totally fine. She is 37 weeks. Can you think the sensitization can occur? Still, yes, even in pregnancy also, during antenatal period also, the sensitization can occur. But the highest risk is during labor. Remember this, even though it occurs during pregnancy, but the risk is very minimal when compared with during labor. So what are all the conditions? This was asked, very important. Any procedure which is going to interfere with the mother and fetus. What are all the procedures we do? So what are all the procedures, you know? What are all the procedures? So chorionic villus sampling, amniocentesis. So whatever the procedure which is going to involve the fetus and mother. Abortions. So why are all these conditions important is, whenever you do this condition, never forget to give anti-D. Okay, anti-D should be immediately given once you do porous villanic sampling in Rh negative pregnancy. Immediately give anti-D. Amniocentesis you have done, give anti-D. So the same, even though it is not a normal pregnancy, ectopic pregnancy, you have to give definitely anti-D in a Rh negative pregnancy. And any placenta abruptia or placenta previa, anything which is going to interfere with bleeding, external cephalic version or any trauma. So these are all the reasons which was asked previously for you. Stripping, not much in stripping. Not much in stripping. But stripping we don't do in early pregnancy. Important thing is we do only it in term. Or once it indicates that we are going to deliver the baby. So stripping, when do we do? It is to induce labor. So automatically it is at the end we do. Okay. Anyway, after the delivery we are going to give anti-D. Yes, answer this. Buffering problem. Yeah, answer. Why you took this much time? ABCD. What is the answer? What did I tell you? Any bleeding, DV buffering problem. So any bleeding it will cause sensitization. So APH. What is APH? Antepartum hemorrhage. So you ruled out section or labor, whatever, anything it is going to cause once again transfusion, sensitization. So post-dated and advanced maternal age, which is ARD. How many of you for D? No D? D. Answer is A. Yeah, Ramya, Bhakti and Shali. Yeah, answer is A. So advanced maternal age. Why not post-dated? What did I tell you? That's what I told you. It's not only the labor and not only during bleeding, but even during the antenatal period, there can be sensitization. So in the post-dated, what is going to happen? The baby is going to remain inside the mother for longer duration. So the sensitization can occur even during that period, but not nowhere related to the age. Is it clear? Yes. Why leaves? What it is going to do? Leaves. Yeah, coming to what are all the other factors which are going to influence the sensitization. So this was asked, very important previous slide what I showed you, the ECV procedures and all, and even this slide. So in Rh negative pregnancy this was asked very frequently. So coming to the size of the inoculum, so even the minimum 0.1 ml of fetal blood can cause transfusion. So what are all the, if the fetal RBC is more, if the maternal-fetal hemorrhage is more, so the chances of sensitization is very high. So the size of the inoculum. Next, is genotype of father important or not? So we know if the father is positive or negative, there are two types within D. If it is homozygous means plus D, capital D, 2 Ds. So the chances of baby getting blood group positive is very high. If the father is heterozygous, capital D, small d, there can be chances yes or no. So if the father is homozygous, more chance of baby getting a Rh positive. So ABO incompatibility. So now tell me, the baby is having ABO incompatibility at the same time. Don't look into the slide, look into my face. So baby is having both ABO incompatibility and RH. So now tell me, either RH and ABO both are present, RH is more severe or less? How many of you less severe? So both are there, ABO and RH incompatibility. So now what about the disease of the baby? Is it going to be more severe or less severe? Less severe? Okay, less. Why? Who said less? Why? Last, why less? Why not more? I say it is more because one side RBC, ABO is damaging, at the same time O positive, this is damaging. So I feel it is more. Yes or no? No, it is always wrong. It is less severe. Why less severe? This was also, remember, in ABO incompatibility, whatever the antibodies are there in the mother. So in ABO incompatibility is the same thing. So any incompatibility, the antibodies are produced. So in ABO already antibodies are ready in the mother. So even in Rh negative, once these fetal antibodies are there, fetal antigens, fetal RBCs are going to occur. I mean, once they enter the mother, what this going to do? These antibodies are going to kill these RBCs. Okay? Because of this fetal RBCs, we are getting antibodies. Yes or no? But this ABO, what it is going to do? Already some antibodies are there. They are going to kill these fetal RBCs. So now no more reaction. So always remember, ABO incompatibility, it is going to be less severe, not more severe. Whereas the size, if the size of inoculum is more, incompatibility is more. So immunological response, it's not like every female should have the same response. There is a norm called non-responders. Even though there are antibodies, some females will not respond. That is a total immunological phenomena. Okay, those are called as non-responders. The incidence is around 30 to 35%. That's why not every Rh negative pregnancy is affected. Only few Rh negative pregnancies are affected. Why? Because most of the around 35% of the females, even though they have antibodies, they will not respond. They don't try to produce antibodies against the fetus. Okay, those are called as non-responders. Does number of pregnancies have an effect or not? Yes, because why? Yeah. Yeah, Ramya, it is correct answer, less severe. Yeah, now answer this. So the answer is A. Next. What is the correct statement out of this? At least if you don't know 2, you know 2. Okay? C or D. Both are correct or not? C and D both are wrong? C and D both are wrong or not? D is wrong. C? C wrong, D wrong. Now what is left out? A and B. Can anyone answer what is the antibody titer? Sheikh has answered it, Ramya has answered it correctly. The answer is A. Why not B? The antibody titer is 16, 16, 16, not 4. Okay? It is they greater than 16 international units, we call it a severe hemolysis. So the critical titer. That's what we call it as critical titer. So now the left out option is serial ultrasound. So if we do serial ultrasound, we can diagnose hydrops early. నాకే కనిపించట్లేదు ఇదేంటో. ఓకే, కమింగ్ టు ఫీటల్, ఆర్ యూ ఏబుల్ టు సీ ద లైన్ సంథింగ్? నథింగ్. Other than this white, are you able to see some other color? Okay, tell me what is first line? So the most common, this was asked for you, the most common fetal affection is. So before going to most common, what are all the fetal affections? So once a mother is Rh negative, how it is going to affect the baby? So there can be either icterus gravis neonatorum, but this is the most common. Other things are either there can be congenital anemia of the newborn or hydrops fetalis. Out of these three, most common is icterus gravis neonatorum. What is icterus gravis? Icterus, what is icterus? So it is mainly because of jaundice. So jaundice develops within 24 hours. Within 24 hours, is it physiological or pathological? So always a pathological jaundice within 24 hours. Now the jaundice is we seen within 24 hours. So when do we call it as kernicterus? What are the bilirubin levels? Direct or indirect? Unconjugated bilirubin. So whenever the bilirubin levels are greater than, even they can cause kernicterus. So the main thing is most common is icterus gravis. It is seen within 24 hours. Always indicates it is pathological. So there can be hydrops fetalis. The serious form. What is the serious form? The question is most serious form of the Rh incompatibility is hydrops. Most common form is icterus gravis neonatorum. So what is this Buddha position? So it was frequently asked, where do you see the Buddha position? Nothing but an X-ray finding. So there will be cerebral edema of the fetal head. It is in something like a halo. Around the head something a halo like a thing is seen. అదే చక్రం లాగా వేస్తుంటారు కదా, ఇట్లా విష్ణుకి చేతికి తిప్పినట్లు ఇట్లా తలకుంటది బేబీకి. Is it clear? So that is a halo is seen around the head. That is nothing but Buddha position. In X-ray it is seen. So what are all the various findings of hydrops fetalis? There can be placentomegaly. There can be anemia, hepatosplenomegaly. So these are all the features of the hydrops fetalis. And on X-ray we see Buddha position. Yeah, Bhakti, it is correct. So what is the pathology in Rh immunization? How it is going to affect the fetus? First thing is, once these RBCs are going to, these antibodies, whatever they are there in the mother, they are going to attack the fetal RBCs. So they are going to destroy this fetus. So what is going to happen? Hemolysis. Once this hemolysis is happening after birth, what it is going to cause? Just now we discussed, what is that name, term? Icterus gravis neonatorum. So jaundice, kernicterus, hepatic failure, and then finally death of the fetus. Suppose if it is occurring in vitro, there can be anemia or not? There can be anemia. So what the body will do to compensate it? There will be increased erythropoiesis. That's why we see hepatomegaly, splenomegaly and all. So there can be hypertension. Because of this megaly, there can be portal and umbilical vein hypertension. Finally, there can be heart failure. That's why the anasarca and hydrops fetalis. Or else if there, because of this increased bilirubin levels, if we come to the down thing. So the increased bilirubin levels, these bilirubin levels are going to increase. So this is the main thing we are going to catch in the investigation. So whenever we are going to investigate Rh negative pregnancy, we are going to catch hold of the how much level of the bilirubin is increased. What is that graph called as? We will draw one graph depending upon the bilirubin levels. What is that graph? Graph. Most commonly we use the graph to diagnose Rh negative incompatibility. How severe it is in mother. We divide it into 3 zones. Lilly graph. Lilly's graph. I'll tell you in the next slides. So whatever this heart failure, it is going to cause erythroblastosis fetalis. Finally IUD. So what are all the various things which can occur in the Rh negative? Icterus gravis neonatorum, congenital anemia of the newborn, hydrops fetalis, erythroblastosis fetalis. Okay. So what are all the things, how Rh negative pregnancy, what are all the effects on the mother? So there can be preeclampsia in the mother. Rh negative pregnancy, there can be a preeclampsia because of the placental involvement, or there can be preterm labor or polyhydramnios. and in RH negative there will be big placenta. So once the placenta is out, big placenta, there are chances of PPH and any IUD. So IUD is going to cause coagulopathies in the mother. Final thing is maternal mirror syndrome. So these are all asked for you. So which of the following is not which is the following is not going to affect in a RH negative pregnancy. So remember polyhydramnios. You will miss polyhydramnios, but RH negative pregnancy once. So what are all the causes of polyhydramnios? Can anyone tell what are the causes of polyhydramnios? Anencephaly, right? Yeah, tracheoesophageal fistula. Next, they will cause either poly or oligo. Atresia, that's what they will cause, poly or oligo. Sure? Most common cause of oligo is renal agencies. So in polyhydramnios it is atresias. Atresia the baby. Why in atresia there is poly? The baby will not be able to swallow the fluid. So everything will be outside. That is going to cause polyhydramnios. Other conditions, which medical disorder can cause polyhydramnios? Medical disorder. That should be definitely ruled out. Yeah. Diabetes, gestational diabetes mellitus. Always remember polyhydramnios, rule out diabetes mellitus. Any placental, one placental cause which can cause polyhydramnios? One placental cause. Mass of the placenta, what do we call it as? Chorioangioma of the placenta. So placental mass, chorioangioma of the placenta, it is also going to cause polyhydramnios. So yeah, we'll come back to the previous slide. Coming to, so what we are going to do, what we give is anti-D. This slide we will discuss at the end. So how we are going to manage this? Suppose the mother is negative, the father is negative. Nothing, no need to worry, we have discussed or not. So we are not going to worry if the mother and father are negative, both are negative. So the mother is negative, father is positive. Now we don't know which baby it is, either it can be positive or negative. So now how I will manage a case of RH negative pregnancy? It's so simple, very simple. So what is the one test you do in the mother to know whether mother is sensitized or not? Where do you do Coombs test? It is indirect Coombs test. Always remember, it's even though it is a very small bit, you get confused here. So Coombs test is used in the fetus, not in the mother. Coombs test is for fetus, whereas ICT, indirect Coombs test, is for mother. So if the indirect Coombs test is positive, it indicates that mother is already sensitized, antibodies are already produced. Now no need to give any anti-D. Okay? If the indirect Coombs test is negative, it shows that antibodies have not yet produced. Now you need to give anti-D. So the first dose of anti-D is given at 28 weeks. Is it clear? So they don't give you direct question, what is the management? They will give you like this. RH negative pregnancy, mother indirect Coombs test was done, it was positive. So which of the following is the management? You are going to deliver, or you are going to give anti-D at 28 weeks, give anti-D at 32 weeks, or wait and watch. What is the management? If it is positive, what you are going? If it is positive, what you are going to give? Are you going to give? Why? Already antibodies are there. Nothing. Why we are giving anti-D? Nothing but whatever the antigens they are going to come, they are going to block. These antibodies are going to sit on the fetal RBCs. They are going to destroy that fetal RBCs so that further immunization will not occur. Already mother antibodies are there, so nothing. No need to give. Whereas in a negative, we are going to give anti-D. Okay. That too first at 28 weeks. What is the T half? T half of this? T half. So until how many weeks it will stay? It will work for until how many weeks? So the anti-D immunoglobulins will last for approximately 12 weeks. T half is different and this is different. So it is approximately going to last for 12 weeks. That's why what I am going to do, even though I give anti-D at 28 weeks, but the term I am going to, once the pregnancy crosses 40 weeks, once again I am going to repeat it. Okay. But always try to remember, don't try to continue RH negative pregnancy beyond term. Why? What is going to happen? Anytime sensitization can occur. Okay. Don't continue beyond 40 weeks. Suppose if it is continued, once again I am going to give anti-D. Okay. So this 28 weeks initial prenatal visit I am going to do Coombs test, and if it is positive I am going to give this anti-D at 28 weeks. Normally, which is the highest risk of sensitization out of the first, second and third trimester? Third, because during that time it indicates labor process. Okay. Coombs test. Yeah, indirect Coombs test is done at 28 weeks. Depending upon that only you will decide whether to give or not. If it is positive, no need to give. If it is negative, then only we are going to give. So 28 weeks as soon as the mother shows. Next I'll come to the management later how to follow. Remember until here. Okay, first I have done ICT. Next how I will manage I'll tell you. So the next thing, infant status. Okay, this birth will leave it off. I'll tell you. So now what I am going to do? These antibodies are there. Okay. This anti-D I have given anti-D 28 weeks and it is going to protect. Now what I am going to do? I am going to do titer. That's what I told you, critical titer. I am going to measure how much is there. Okay, how much critical titer is there. I think that slide is there. I will show you that slide. Yeah. See the critical titer. Okay, we will finish up this before slide, then we will come back. So if the infant, the dose is determined, administration is no. So the T half is normally 24 days. You remember these 3 points. First thing is, it will work for 12 weeks. Next is T half is different. The T half is 24 days, not 12 weeks. Next it remains in circulation for 6 weeks. These 3 are different bits. So it can remain in circulation for 6 weeks. The T half is 24 days. Yeah. So next what I am going to do, if the antibody screen is initial positive with RH positive, what I am going to do, I am going to measure this antibody titer. How much titer is there? So if the titer is less than 1:16, nothing to be worried. So if the critical titer is greater than 1:16, what I will do? In this critical titer, there can be any chance of whatever the titer, this antibodies at any time they are going to damage the fetus. So I should measure how much this titer is there. If it is greater than 1:16, it indicates that it is going to damage the fetus at any time. So I have started doing this titer at 28 weeks. So now what I will do, I am going to repeat this titer once again. After every 3 to 4 weeks I am going to repeat. So because of this titer, I am going to know whether the fetus is affected or not. So if the titer keeps on increasing, now it is 1:16. Once again I have repeated, if the titer is going to increase, definitely the fetus is going to affect it. But I should know how much fetus is affected and how it will affect it. So which value I can measure? Previously we have discussed bilirubin. Bilirubin means what does it indicate? It is indicating the fetal damage. Where is the bilirubin released from? RBCs. So whatever the antibodies are there, they are going to destroy these RBCs. So they are going to release bilirubin. Now what I will do? If the antibody titer is very high, means more antibodies, more RBC damage, more bilirubin. So the amount of the bilirubin, it gives a clue to me. How much damage is there inside the mother? Okay, I am going to measure that bilirubin. How I am going to measure? I will do an amniocentesis. So from the amniotic fluid, I am going to take the bilirubin. That to what we call it as amniocentesis. We will see. So now the antibody titer, if it is less than 1:16, the hemolytic disease is low. Is it clear now why the titer is important? So now if it is less than 1:16, nothing to worry. Repeat it and monitor it. Okay. If it is greater than 1:16, repeat it. Once again it is increasing. So now what I will do? I need to know how much the antibody titer, how much bilirubin is left. So I am going to do amniocentesis. So what is the timing of the amniocentesis in a Rh negative pregnancy? The first thing, this was asked for you. If the previous baby was not affected the first time, so this is the first pregnancy, you have done ICT, ICT is positive, you have done antibody titer, the antibody titer is greater than 1:16 now. After 1 month I have repeated, now it increased to 1:32. So now I want to do amniocentesis. So previously no babies, this is the first pregnancy, or previously the baby whatever is there, it was normal. So I will do at 30 to 32 weeks. Okay. If there is a past history of affected baby, 10 weeks prior to the baby, suppose the baby in the past pregnancy was affected at 28 weeks. So now when I have to repeat it? The previous baby RH negative, it got affected at 28 weeks. 18 weeks, so minus 10 weeks. So now I should not wait until 32 weeks. By the time I wait until 30 to 32 weeks, nothing but hydrops fetalis baby, or there can be IUD. So now I have to detect very early. So what I will do in any past history of previously affected baby 10 weeks prior to the when the baby was affected. So, but remember that very important thing is we will not get anything if we do prior to 20 weeks. Why? If prior to 20 weeks, even though you do amniocentesis, whatever the procedures, you may not get correct values. Why? Because the baby's immune system is immature. Why the fetal RBCs are going to get transmitted, whatever the bilirubin levels, the hemolytic disease, and all these are not seen because the liver itself is not formed. I mean, even though the liver is formed, the enzymes, it will not be releasing the enzymes. So, the physiologically the liver is not ready in the baby before 20 weeks. So, because of total immature immune system, we may not see this hemolytic disease in newborn as early as less than 20 weeks. Okay. Whatever the pathology, we see it greater than 20 weeks. So, what I am going to do with this amniocentesis? Amniocentesis, that's what I told you. From amniotic fluid, what substance I am going to take? Bilirubin. Bilirubin levels. I am going to measure the serum bilirubin. From where these bilirubin levels have come? RBCs. Which RBC? Fetal RBC. Damage of the fetal RBC. So, we are going to take that bilirubin. That's why we are seeing it in the amniotic fluid. We are not taking from the mother. We are taking the fetus, fetal amniotic fluid. So, the bilirubin, normally what it is going to do is, it has some optical density. So, optical density of amniotic, normally we measure the optical density of the bilirubin. So, normally 250 to, in between 250 to 700 mm we can see the optical density, but around a 450 mm there is a bulge. So, once you draw a graph of this bilirubin levels at around 450 mm we will see a bulge. But height of the bulge is very important for you. That's what we call it as Lilly's chart. So, this is the Lilly's chart. So, this is the gestational age, and wherever the bilirubin levels, optical densities, what did we say? Approximate is 450. So, from 0.4, 450 nanometers, we are going to divide into 3 zones, zone 1, zone 2 and zone 3. So, what is this zone 1 and zone 2, zone 3? Nothing but wherever this height, depending upon the height, we are dividing into zone 1, zone 2 and zone 3. So, this graph is called as Lilly's graph. This graph is nothing but Lilly, L-I-L-E-Y. This graph is very important. So, depending upon this graph, we are going to manage the entire pregnancy. So, how we manage this pregnancy? And one more other alternative. So, I don't want to do an invasive procedure. Amniocentesis is an invasive or non-invasive? Invasive procedure. So, sometimes I can go with non-invasive, like middle cerebral artery, Doppler, middle cerebral artery. So, I am going to measure the peak velocities and I will divide it into A, B, C, D, 4 groups depending upon the velocity, peak velocity of the middle cerebral artery. What does middle cerebral artery indicate? Why middle cerebral artery? Anemia. So, the flow of the middle cerebral artery is going to reflect the anemic status of the fetus. It was asked for you. So, which of the following will reflect the anemic status in the fetus? So, the middle cerebral artery which shows a abnormal flow, it is going to indicate that the fetus is anemic. So, which Doppler finding is going to show that the heart is affected totally? That the baby is in cardiac failure. So, which Doppler? Middle cerebral shows us anemia. But already the baby entered into anemia, even cardiac failure. So, by doing Doppler of which vessel, we know that the baby is already in failure. Ductus venosus. Okay. By doing Doppler of the ductus venosus, we are going to note that the baby is already in cardiac failure. So, we will go back to the previous thing. So, remember, not only just the amniocentesis and Lilly's graph, other alternative is middle cerebral. What are the other vessels we do Doppler? Umbilical and other than middle cerebral artery. That I told, ductus venosus, middle cerebral artery, other than umbilical, one more, most artery. Doppler for that vessel. Then only we go to all other vessels. ఫస్ట్ వెజల్ ఈ వేరియేషన్ వస్తుంది, లో హై కదులుతుందనా? Uterine artery. So first what I am going to do? I am going to do Doppler of the uterine artery. Next only to the fetus. First I am going to see to the mother how the blood supply from the mother is to the fetus. So uterine artery. So what are all the vessels where you can do Doppler? Uterine artery, umbilical artery, middle cerebral artery, ductus venosus. So 4 vessels. Yeah, Kausar, it is correct. Uterine artery. So telegraph. The very important findings. They have asked many bits. So how do you manage zone 1, zone 2 and zone 3? So which is zone 1? Zone 1 is below, zone 2 is above, zone 3 is very high. So this how we divide. So what we are going to do? In zone 1, always nothing is going to happen to the fetus. Observe the fetus. So in zone 1, how we are going to manage the fetus? If the graph shows the bilirubin, it indicates that the levels are very low. Okay, the bilirubin levels are very low. What I am going to do? I am going to continue pregnancy until term. Okay. So I am going to continue pregnancy until term. But one vigilant thing, I am going to repeat it every monthly. Okay. I want to recheck the values. So in zone 1, either you want to continue or terminate. Continue, always continue pregnancy till term. Coming to zone 2, it indicates that it is a moderate disease. So it will require treatment. I will tell you how we are going to manage in zone 2. Even in zone 3, it doesn't indicate that immediate delivery. So there is different management for zone 3. Always remember, zone 1 you are going to continue pregnancy. Zone 2 and zone 3 you are going to do further tests. Okay. Then you are going to decide what to do. So this is zone 1, zone 2, zone 3. So zone 1 continue pregnancy. So in zone 2, but after how many weeks I am repeating? 4 weeks. Remember, after 4 weeks, not 2 weeks. In zone 1, when I am going to repeat? After 1 month once again. Whereas in zone 2, it is a moderate disease. Now I can't wait for 1 month. The baby will die. So now I have to remit within 15 days. I have to do this test. So once I do repeat amniocentesis, what I have to do? So if the values are going into zone 3. So zone 1, first I have continued pregnancy. Until term. Nothing to get worried because low bilirubin. So in zone 2, what I will do? In zone 2, once again I have repeated after 15 days. But the values are going, there are 2 processes. One is the values can go either lower or remain in the same or come back to zone 1. So once the values are reaching upwards, I mean zone 3, going towards dangerous zone, what I need to do? Baby, now what I have to do is I have to do cardosynthesis. What do you mean by cardosynthesis? Collecting blood from the umbilical cord. So what I am going to do with that blood? I am going to measure hematocrit value. So if the hematocrit, it indicates the anemic status of the fetus. If the hematocrit is less than 30%, it is indicating that the fetus is landing in anemia. So now I want to avoid that anemia. What I will do? Intrauterine transfusion to the, directly I am transfusing blood to, not to the mother, directly to the fetus. That is intrauterine transfusion. Okay. And if it is in zone 2, I mean if it is in anemic status and if you are giving intrauterine transfusion, always do delivery at 34 weeks. Okay. If nothing, if everything is fine, just continue pregnancy once again. If it is falling down under zone 1. Is it clear? Now what I will do in zone 3? Zone 3 is dangerous zone. What does it indicate? It indicates that there can be death of the fetus within 10 days. But it doesn't indicate that you have to immediately do cesarean section or deliver. So now what I am going to do? Even this zone 3 also, if the pregnancy is less than 34 weeks, normally when do we call it as the fetus is mature? 34? Viable is 28 weeks of gestation, we call it as viability of the fetus. Normally when do you want to continue the pregnancy, normal pregnancy? Which is the dangerous, I mean once that period weeks of gestation is crossed, even though the baby is going to deliver, nothing is going to happen. What is that? 37 completed weeks. Whereas nowadays because of high neonatal care, intensive care, it has come down to 34. Even in foreign it has gone down to 32 weeks. Okay. So in which other condition we are going to terminate at 34 weeks? Preeclampsia. Severe preeclampsia. Okay. So in pregnancy less than, what I am going to do? Even though zone 3, remember you are not going to deliver, So as soon as you see zone 3, don't mark the answer as delivery. Even in zone 3, I am not going to do immediate delivery if it is less than. So the question will be very tricky. A 28 weeks of gestation, Lily's graph is done, it has shown zone 3. What is the management? Seeing the zone 3, what you will do? Immediately you will go for delivery. But the weeks of gestation is 28. Are you going to do delivery now? No. Less than 34 weeks, I just want to do only cardosynthesis. Once again, measure the hematocrit. If it is less than 30%, you give intrauterine. When to give until how many? How many intrauterine transfusions? 1 is enough, 2 is enough, 3 is enough, or 10, 12, how many? How you will decide? Until the hematocrit value is raised until 40 to 50%. So the hematocrit value should be raised until 40 to 50%. So give transfusion until that time. Once the hematocrit value is 40 to 50%, then you can stop. Okay. So if it is greater than 34 weeks of pregnancy, go for termination. Zone 3. Yes, is it clear? Can you tell me now how do you manage zone 1? That's it. Repeat. So you want to repeat it. When do you want to repeat it? So every 4 weeks, 1 month. How do you want to manage zone 2? Okay, repeat after 2 weeks. Next. Transfusion. Okay. So once you repeat, if it is going towards zone 3, then only you are going to do. If not, manage it. Okay. Next, zone 3, how you are going to manage? If less than 34 weeks, go for cardosynthesis. You are not going to do directly intrauterine transfusion. The cardosynthesis shows 40 to 50%, no need of intrauterine transfusion. Okay, if it is only less than 30%, then only we are going for intrauterine. If it is something 50-60, now no need to do. Why we are giving blood? Because it is indicating that the fetus is anemia. We want to correct the fetal anemia, or else the baby will go into cardiac failure and die. Okay? Yeah, exchange blood transfusions. So other than this, what you are going to do? So other than this, you need to do serial ultrasound scans. Previous bit we have seen. Why? To detect hydrops fetalis early stage, at an early stage. Next, other alternative what we have is middle cerebral artery, Doppler. So how do we divide it into A, B, C, D? Okay. So it is not much useful, but remember the middle cerebral artery Doppler is also used. Why? For to detect which? Anemia. And delivery. Coming to delivery, if it is mild anemic, we can, that's what, you can continue the pregnancy until term. If it is a severe anemia, immediately we may have to terminate by 34 weeks. If it is less than 34 weeks, go for intrauterine cardosynthesis, then measure hematocrit, then intrauterine transfusion.
We can't transfuse blood and then deliver. If it is just around 24 weeks, we can't transfuse blood and then.
That's what, depending upon the hematocrit. If the baby is fine, why you want to deliver it? Depending upon the hematocrit. Why we are delivering at 34 weeks in zone 3 even though the baby is not anemic? It is zone 3, but the baby is not, hematocrit is 40 to 50%. I said greater than 34 weeks deliver. So now it is 35 weeks. So as per my explanation, you have to deliver. Why you have to deliver? Zone 3 is, what is zone 3? Zone 3 is indicating high levels of bilirubin. High bilirubin, what does it indicate? So the next the fetus is going to land in a state of anemia. Even though now the baby is not in anemia. Next within 1 to 2 weeks, immediately the baby can land in anemia and death in any point of time. So you need to terminate the pregnancy. So the very important thing next is, so the fetus is born. So everything is successful. So we have maintained, we have delivered successfully as per the protocol. Now the baby is out. So how do you manage the baby now? So you want to do some tests for baby? Or for every RH, why we have to do? First of all, what are the tests and why we have to do each test in the baby? What are all the tests? So RH negative, the important things in labor. What are all the important things during labor? We have discussed already. During labor, RH negative, which injection you are not going to give? Yeah. Antase ఆలోచిస్తారు, ఎవరు ఆన్సర్ చేస్తారు? Methadone, you should not give in RH negative pregnancy. Methadone vasoconstriction, once again it is going to cause hemorrhage, fetal-maternal hemorrhage. So next, what other thing you are going to do in second stage of labor in RH negative? cut short the second stage of labor. Okay, next important point is leave the length of the cord for long when compared with normal. Why we have to leave the long cord? So on baby, we don't know the baby can land. Icterus gravis neonatal is seen in which phase? After delivery. So the baby can land in jaundice or anemia. We don't know. So we may have to give intrauterine transfusions to the baby, extrauterine. So the cord of the length of the cord should be always kept long in a Rh negative pregnancy. Okay. Coming to fetus. Once the fetus is born, first now what I am going to do? So in Rh negative, always remember to collect some blood, cord blood. So never forget to collect cord blood. If the cord blood is missed, at least try to take the sample from the fetus directly, the baby, born baby. So first I am going to do is HB percent of the baby. So why HB percent? To know anemia. Next, what is the second thing I am going to do? Important thing. What I should know now? The baby's blood group. Blood group I should know. It's very important. Yes or no? So now I have to do baby's blood group. And even I will do peripheral smear of the baby. Why? To see any abnormal cells. Already the hemolysis has started or not. Next, what other thing I am going to do in baby? Important thing. Fourth one. Which test? In mother which test? In baby which test? Coombs test. So Coombs test indicates antibodies whether they already have entered the baby or not. Okay. So these are all the 4 important things what I am going to do in the baby. Once you keep it aside, any Rh negative mother with a positive. So the baby blood group has come. It has come as positive. So now what I am going to do? I should give anti-D to the mother, because why anti-D only now in the Rh positive fetus? Positive fetus only going to this RBCs are going to enter the mother. They are going to cause antibodies. So once the fetus is Rh positive, give anti-D. How much anti-D I have to give? I don't know. I have done normal delivery in case. Suppose a patient is normal delivery. How much dose you will give? Suppose a patient is cesarean section. How much dose you want to give? A patient with normal delivery but with PPH. How much dose you will give? So how do you calculate the dose of the Rh negative? But always remember, we don't, every time the patient delivers, we don't calculate, and then give the dose. But less than 12 weeks, suppose a Rh negative with abortion, less than 12 weeks, the dose is different. Greater than 12 weeks, the dose is different. So less than 12 weeks, 50 mics, okay, of anti-D. Greater than 12 weeks, 300 mics, okay. This is the normal value or normal protocol we follow. This is normal. But if you want to calculate it, what are all the various methods to calculate it? So that is the test called as Kleihauer-Betke test. Okay, I think it is in the next slide. So now the standard dose, why we are giving it as 300? Why only 300? Why not 200? Why not 500? Why not 600? Why that 300 dose is fixed standard as 300 greater than 12 weeks? Because this 300 whatever the mics is there anti-D, it is sufficient for 15 ml of D positive fetal RBCs. Remember, this is asked for you. So it will combine with this RBCs and it is going to destroy this, and I mean it is not going to kill the RBCs. So whatever the antigen sites are there, they are going to, these antibodies are there. So they are going, suppose this is the fetal RBC. So it is having this antigen. So what it will do? It will go inside the mother and it will create antibodies. Instead of that, once you give anti-D, what it is going to do? These antibodies, they come and sit here. So they will block these sites. Further there is no immunological reaction. So no recognition. The mother will not recognize them as foreign because these sites are blocked by the anti-D. That is the function of anti-D. Is it clear? So normally how much ml? Whatever the 300 mics of anti-D we are going to give, it is going to compromise. When we take fetal RBC, it is 15 ml. When we take whole blood, it is 30 ml. Okay, it was asked for you previously. Yeah, Kausar, it is very good point. One more important thing in Rh negative pregnancy you should do is early cord clamping. Okay, where else we do early cord clamping? Where else you do early cord clamping? Recently? Yes. So in a diabetic mother and even in HIV in pregnancy. So these are all the conditions where you do early cord clamping. So remember this value. It is 15 ml of the fetal RBCs, whereas if it is 30 ml of the whole blood. If they ask you how much this 300 mics is going to compromise, how much ml of fetal RBC, so it can clear 15 ml of the fetal. But we are getting only 0.1 ml normally, that is the minimum. But normally 3 to 4 ml is sufficient to cause sensitization. So 3 to 4 ml of fetal RBCs will be there, but 300 mics can even compromise 15 ml. So that is the dose we are giving. If it is whole blood, if we take total fetal blood, it is 30 ml. Okay, these two bits are asked for you. RBC is half, the blood is double. So I need to know clearly, but I can't just guess this. So how do I measure how much amount of feto-maternal transfusion is there? So I will do one test, the Rossetti test, otherwise called as Kleihauer-Betke test. So remember, where do you do this Kleihauer-Betke test? So Kleihauer-Betke test is done in Rh negative pregnancy to know the amount of sensitization. So how much amount of fetal RBCs has entered the maternal circulation. So what is this Kleihauer-Betke test? It is nothing but an acid elution test, otherwise called as acid elution test. So I will take a sample from the mother, blood sample. Now it contains both what? Maternal RBC, fetal RBC. Now how to diagnose this maternal RBC and fetal RBC? I will put some acid, citric acid phosphate buffer. Okay, that is called as citric acid phosphate buffer. I will put on the, I will take a smear, I will put that buffer on that. Then I will examine it under microscope. So if it is a fetal RBC, they will remain, their resistance. Feeta koncham, kuta ganam. Remember, okay? This was asked for you. So the fetus is resistant, the fetal hemoglobin is resistant. Whereas adult hemoglobin, it is going to get lysed. So once you see it, the fetal hemoglobin remains. It is going to resist the acid. It remains. Now we will count how much fetal RBCs are there. Now we can know how many fetal cells are left out. Okay? That's how we calculate. Is it clear? Important point in this total procedure you need to remember is it is otherwise called as acid elution test. So the fetal hemoglobin is resistant. They are going to be seen. Adult, they are going to get lysed. I mean, they are going to get stained in a different thing. But what we are going to see is fetal RBCs. Clear? It is otherwise called as acid. So this adult hemoglobin red cells are washed out by the acid. Why? Fetal hemoglobin are not. Okay. Now we are. You want to see this how much fetal RBC is left out. Now we send it itself. So we can, they appear as red. Okay. Already these adult cells are lysed out. They appear as transparent. So important thing is the fetal hemoglobin is resistant. Now we are going to count how much fetal number of red cells are there. Okay. This we know. 50 mics, 300 mics. Yes, answer this. ABCD, that's what I told you. I already explained this bit. Yeah, Ramya, it is correct answer. Ramya, correct answer. Yeah, what is the answer? ABCD. A, yes or no? B? B, how many of you want to say yes? C? C, so what is the other answer? If A is wrong, B is wrong, C, yes or no? C is yes. D? D, no. So B and C. Now tell me which is correct. So zone 3, in zone 3 but not greater than 34, less than 34. What is the management? Cardosynthesis, that's what I told, repeated you many times, less than 34, but zone 3 is dangerous zone. I can't leave the baby like that. I have to do cardosynthesis, measure the hematocrit value. Then go for intrauterine transfusion. Are we going to do delivery? Why? Is it clear? Mani and Bhakti, I already explained you should not do delivery because the gestational age is just 28 weeks. If it is greater than 34 weeks, then we can go for delivery. Transfusion. Transfusion, cardosynthesis, don't wait. Once the amniocentesis you have done, it is zone 3. Now no point in repeating. It is zone 3, zone 2 or zone 1, repeat it. Okay? Yeah, that's what in cardosynthesis we are going to do what? Hematocrit. Even though we didn't measure or not, out of the 3 options, we are not going to do amniocentesis. In zone 3, don't repeat the amniocentesis and wait. Okay? The left out option is either intrauterine transfusion. Okay? Or delivery. But delivery we are not going to do because 28 weeks. This was asked, this was Ames question. So yeah, answer this. Answer. When are you going to give? Except. And one more thing is the mistake even I do sometimes and most of you do is remember that except they have asked. So we will miss that except. Nicely the examiner has misguided you. Very good question. That's what I made it as if. Huh? That's what I am telling. The examiner has misguided you. Very nicely has misguided you. Come to the basic. What I taught, come to the basic. The chart is here itself. Relate this chart, the question with the chart. RH negative pregnancy is very easy if you understand it. It's not a tough one, something like a very complicated. It is very simple. I told you very clearly. Yeah, Bhakti, the answer is correct. Deepti, Meher, Mani, the answer is wrong. Just relate this chart. I am showing you the chart. I am giving you a clue. See, I am giving you, just relate this chart with that question. This chart can give you answer. The examiner has nicely misguided you. The question is very good question. You are not looking into the main thing. Side curry, the main dish is something. Everyone is watching into the side dish. You have left main hero. Why is it? So, blood group ki deenki relation enti? Coombs test we are going to do only in the baby. This is in mother. Avunu, we do Coombs test in mother or baby? Coombs test where do we do? Where do we do Coombs test? That's what. So whatever you want to say correctly. If you now say Coombs test in even in big answering also you are going to say Coombs test. In mother which test? Indirect Coombs test. So now tell me indirect Coombs test. So simple. The question is so simple. Anti-D should be given in all except. So when we are going to give anti-D if the ICT is negative. So this anti-D if it is negative then anti-D then 28 weeks. Once again at term delivery. If the ICT is positive then only we are going to do all this process. If the ICT is positive titer we are going to measure then repeat amniocentesis then cardiocentesis everything. Okay. Anti-D where we are giving? Are we giving in anti-D? Why we are not giving in intrauterine transfusion? Inka artham kaleda? Half of the people understood. Okay, I will make it clear. So anti-D should be given in all except. So anti-D when we are going to give? First tell me. ICT we have done. If it is negative, how I will manage? I will give anti-D. Okay, I will give anti-D at 28 weeks. Then at term. Then I will deliver. Management is finished. Whereas, so when we are going to do anti-D, any abortion, any amniocentesis process, any placenta manual removal or any process which is going to cause fetal-maternal hemorrhage. Why not intrauterine transfusion? Intrauterine transfusion, when are we doing this entire process? The ICT is positive, what I am going to do? I am going to measure antibody titer. That is 1:16. 1:16, then going for amniocentesis and cardiocentesis, measuring bilirubin levels, then divide this. Okay, are we giving ICT in this? Anti-D in this? Because already ICT is positive. Even though if you give already antibodies are there, no use. Is it clear? Just remember this chart. I am able to see good question mark faces. Is it clear? Already in intrauterine transfusion I am not going to give ICT is positive. It indicates no need to give anti-D. So once this positive then only I am going to do this entire process. Intrauterine transfusion is indicating already antibodies are there. Already they are damaging the fetus. Now even though if you give antibodies, no use. Already antibodies are there in mother. Is it clear? Is it clear? Online money you want me to explain once again? Yeah, fine. Okay, anti-D, first of all, when we are going to give anti-D? First, in RH negative, I am going to see ICT levels in the mother. If it is negative, then only I am going to give anti-D at 28 weeks under term and then deliver. If the ICT is positive, already it indicates that already there are antibodies in the mother. So, no need to give anti-D. Now, I should check how many antibodies are there, because the amount of the antibodies, they are going to cause damage to the fetus. So, the antibodies are there. Once again, I will check the titer. Depending upon the titer, I am dividing it to 3 zones and managing the further mother and the baby. So, it is indicating that already antibodies are there. Now, no need to give. Because we do intrauterine transfusion where? Only in this Lilly's graph. Once the ICT is positive. Okay? Avun Babu, intrauterine transfusion, it's indicating when do we give intrauterine transfusion? So, when do you want to give intrauterine transfusion? Tell me. You will tell me. Now, in written you will tell me. I will ask you, you will understand. Tell me. When do you want to give intrauterine transfusion? Please, let him answer. Hematocrit is less than. What it is indicating? Hematocrit is less. So, it is indicating where the baby is landing. Why the baby is landing in anemia? Why the baby is landing? Why the baby is landing? Why? Hemolysis. Why the hemolysis? Antibodies. Where does the antibodies are coming from? Already there are in antibodies in mother. There is now no need to give anti-D. So once the antibodies are there in mother, there is no point in giving anti-D. Is it clear? That's what the first basics we have discussed this chart. That is the side dish I told you. So the main dish is you have left this and you are looking at the 28 weeks, 16 weeks, 13 weeks. That is the side dish. That's what I told you. Whoever the author framed this question, he has nicely misguided you. So you are looking, everyone is looking 16 weeks, 28 weeks, which weeks? But you have left out the main point. Okay? That's what I told you. Don't look on to the side dishes. First look on to main thing. Okay? Is it clear online? Yeah, next tell me. It is not very complicated. Just think basics. That's it. Which is not a complication of RH. There can be APH. How? How can there be PPH? PPH in RH negative is due to because of PPH last row. Big placenta, placentomegaly. So PPH is because of placentomegaly. So APH is due to there can be even IUD coagulopathies. Okay, APH can be there, but not oligohydramnias. What will be there? Polyhydramnias.